started. Good afternoon and welcome everybody to this month's Million Hearts Learning Lab using self-measured blood pressure monitoring to improve maternal health equity and reduce maternal mortality. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in our clinical affairs division, and I'm pleased to bring you this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. First things first, this event is being recorded. Just want to put that out front. If you do not feel comfortable in this session while it's being recorded, we ask that you kindly leave. This content will be available for playback. On the front of your screen, you'll see a little slide right here that indicates that Q&A box. Q&A box is open for the duration of this event. We do have a chunky section at the end of today's session. We'll be able to answer your questions live in the time allotted. Simply type your comments, questions, or concerns into this box at any time. You do have the ability to upvote questions. So if you see something that you like that your colleague has already put in there, feel free to give that a thumbs up. That kind of puts that question to the top of the queue. If you want to submit your question anonymously, if you can see that on the top of your screen, there's a little checkbox that you mark. And we don't know who that question came from, but we'd be happy to answer that. Again, friendly reminders, today's event is being recorded. All audio and video has automatically been disabled. This is really to avoid any sort of background noise interference. Again, we encourage you to submit your Q&A in the Q&A box at any time during this event. At this time, I'd like to turn things over to my colleague, Leanne, who's going to be introducing today's speaker and setting the stage. Leanne, the floor is yours.
Thank you, Liz. Greetings to everyone who is joining us today. Welcome to our Million Hearts Learning Lab. This Learning Lab is a learning series co-sponsored by the CDC's Million Hearts Initiative and the National Association of Community Health Centers, which is focused on cardiovascular disease prevention and management topics. This series is open to clinicians, quality improvement, and other interested staff across the country. Next slide, please, Liz. So if you're new here, I'd like to take just a few moments to provide you with some context about our learning lab. We use a mixed methods approach that takes a total time of 60 minutes, which is divided into 3 distinct parts. We have a pre-work video recording, a pre-work survey to gather your questions, and then today's live session or discussion-based event. We hope you've already watched the pre-work recording, which is an excellent short micro-learning that can be used for training your clinicians and staff well beyond today's event. So I definitely encourage you all to access it and share it widely. Our live event will be 45 minutes long and will provide you with information on how to apply for CE credits towards the end. Next slide, please. Today's learning objectives focus on highlighting the growing disparities and inequalities in maternal mortality outcomes in the United States, providing best practices for diagnosing and managing hypertension during pregnancy, and demonstrating how to strategically coordinate care using self-measured blood pressure monitoring to support the most at-risk populations post-pregnancy. Next slide, please. I'd like to provide just a quick disclaimer that the opinions expressed by authors do not necessarily reflect the opinions of that of the government. And then next slide, please. So I'm very pleased to introduce our moderator for today's Learning Lab, Dr. Janet Wright. Dr. Wright is a cardiologist by training and currently serves as director for the Division for Heart Disease and Stroke Prevention at the CDC. From 2019 to 2020, Dr. Wright completed a 2-year assignment in the Office of the Surgeon General as the Acting Director of Science and Policy. In that role, she was instrumental in several Surgeon General's calls to actions, including calls to action on hypertension and on maternal health. From 2011 to 2019, Dr. Wright served as Executive Director of the National Millions Heart Initiative. We're so pleased to have you, Dr. Wright, for joining us today. So I'll turn it over to you.
Thank you so much, Leanne. It is a joy for me to join everyone today. And thanks to the Million Hearts team and to the NAC team for setting up this wonderful learning opportunity. I am so privileged to be in the middle of the experts that have joined us today. And I'd love to introduce them to you all. Maybe a next slide. There we go. So we have Dr. Ukachi Imeriwa from the University of California, San Diego School of Medicine, Lady Segas, the CEO of the Preeclampsia Foundation, and Dr. Lisa Green, Chief Executive Officer of the Family Christian Health Center. Each of these people, who happen to be women, have deep expertise in hypertension, in women's health, and particularly in hypertension during and following pregnancy. And they all bring complementary perspectives to bear on our conversation today. So next slide. I just want to hit the high points of a few things. And I think the rolled up message I want to leave you with is that hypertension in pregnancy and postpartum is increasingly common in the United States. It is dangerous and it can be deadly. So common. 1 in 2 of us adults in the United States have high blood pressure. We know that the control rate is down around 23, 25%. So of all of us who have high blood pressure, about 1 in 4 of us has it under control. Out of all those millions of people who have high blood pressure, 59 million are women. 59 million women have high blood pressure in the country. And of that group, about 1 in 5 or 20% are of reproductive age, roughly 18 to 44 years of age. So again, hypertension is common in this population. 1 in 10 women in the US will have some type of pregnancy-associated hypertension. They either go into pregnancy with chronic hypertension or develop it during the pregnancy, or may even develop it in the postpartum. And as you know, some forms of that hypertension can be severe and life-threatening. While hypertension is dangerous for all women, Black women, American Indian women, and Alaska Native women have even higher rates of harm of pregnancy-related hypertension. The last fact is that the harm from hypertension does not end at the end of the pregnancy. Having hypertension during pregnancy more than doubles the risk of developing chronic hypertension after that pregnancy, and we know it elevates that woman's risk of developing cardiovascular disease over the course of lifetime, and actually accelerates the onset of that cardiovascular disease. So it's as though a woman with hypertension during pregnancy gets a tattoo that marks her for elevated risk of CVD throughout her life. It also threatens the life and the health of the fetus and the newborn of that pregnancy, either preterm birth or growth restriction. And newer evidence is beginning to show that the child of a hypertensive pregnancy also has an increased lifetime risk of developing heart disease and stroke. So there's every reason in the world for us to bring our attention to the detection and control of hypertension, because these harms are largely preventable. And that's why I'm so excited that you all have joined today. You're clearly expressing your interest and your commitment to this mission, and we love joining that mission with you. So let's focus today on how to better detect and control hypertension, and it's time to bring in the experts. Next slide. Thank you. So we'll do a few questions. And Dr. Mariwa, I'd like to start with you. I remember the moment when I began to understand that when it comes to heart attacks and strokes, the action is not in the clot or the stenosis, it's actually in the lining of the blood vessel, the endothelium. I think you have shed light on this idea that the placenta is the site of all the action when it comes to a hypertensive pregnancy. Could you say more about that? Explain to us what's going on at the placenta level.
Sure. Yeah. Good morning, everybody. Hi again. Thank you for joining. I'm very excited to be here to talk about such an important issue. And Dr. Wright, I'd like to, I chuckle a little when you say that, because as I was thinking about how to describe preeclampsia and it being a placental problem, I gave my brother a call, who's also a physician, but home critical care. And I said, how do I boil non-pregnancy hypertension into like a single concept? And we had such a lengthy discussion about how to boil it down to underlying risk factors. But I will say the one positive thing I will say about preeclampsia is we do have some decent understanding of the root of the problem. And I think the reason why it's so important to understand this and know this, and the reason why I actually take time with my patients to take a step back and help them understand it, is because you can't act on something you don't know, and you certainly can't act on something you don't really believe in. So we really have to understand how it's distinct from non-pregnancy hypertension to know why it's so critical. So I often tell my patients, colleagues, anybody I'm speaking with, that preeclampsia really is a placental problem. And the reason I say that is, unlike, I'll have many patients come in and they'll say, I think we should do X, Y, and Z to reduce your risk of preeclampsia. Take a baby aspirin, check your blood pressure, as Eleni and Segas will get into at some point. And they'll say, oh, I'm a healthy eater. I exercise all the time. My lifestyle is completely perfect. Like, I can't be at risk of high blood pressure. And I say, well, unfortunately, preeclampsia is something that is almost entirely out of your control. We have a couple things that can reduce your risk, but it really is a placental thing, meaning however the egg and sperm came together and created this embryo that established a little placenta and decided to set up the way it set up shop, you can't control that. And what happens in preeclampsia is it's an issue of how the placenta kind of establishes its first blood supply. So we think, obviously there's still a lot we're learning about it, that releases certain factors, releases certain proteins into the bloodstream that then impact your blood vessels and can lead to hypertension, can impact your organs, your kidney, your liver, the brain, cause seizures. So you can live as perfect a life as we can, whatever we're calling a perfect life, and that still won't mean that you're not at risk of preeclampsia. And I think once we as providers, our patients as patients, understand that, we understand why anybody can be at risk. Now, that's not to say that if you don't come in with certain risk factors, right? If you already have underlying hypertension, any organ that preeclampsia can affect, if it's already compromised, right? People have hypertension or underlying kidney disease. Of course, we're more worried about starting at baseline kind of compromised function and then preeclampsia impacting that. But anybody, unfortunately, is at risk of getting preeclampsia because it starts at this placenta that you did not have so much control over how it formed and set up shop.
Thank you so much. It is an intriguing area, and I'm so grateful that you are doing research in this area because there are many more shards of light that you're going to shine on the issue of the placenta.
I think, can I just
Yes,
jump
please,
in and
Eleni.
say one other thing about that? One of the reasons that it very much aligned with kind of presenting it that way is that also helps people realize that placenta, which is an organ unique to pregnancy, is what connects mom and baby. And so when you think about the impact that this disorder can have, it can also impact the baby. And so it helps people understand that this is an issue that affects mom's health, and it's an issue that can affect the baby's health because it is essentially like a dysfunction of this organ that's connecting these two pieces. So I love that framework. Aside from why it is biologically plausible, it also helps people understand why we need to care about mom and baby.
The lifeline, literally.
Yeah.
Thank you, Eleni. So, Dr. Mario, I'm going to come back to you. The placenta is complicated. Hopefully, slightly less complicated is the treatment of hypertension during pregnancy, but there are nuances there. What would you tell those gathered today about treatment of hypertension during pregnancy?
Sure, like you said, slightly less complicated. So I'll try to simplify it in a way that you can have a good takeaway package. I'm going to start with treatment of severe hypertension, which hasn't changed in some time. And I think is kind of, if you know one thing, like if you know two numbers, one systolic and one diastolic number to pay attention to when a patient who is pregnant or recently postpartum comes to you, it's the severe hypertension number. And that number is a systolic 160 or greater, or diastolic bottom number 110 or greater. And, getting that number in our head is important because if a person who is non-pregnant comes in off the street and your blood pressure is 160 over 110 and you have no symptoms, nobody's going to feel the need to keep you in an emergency room, right? Like, not to say it's not important, but the reason it's different is because not only is the sensitivity of our blood vessels for the pregnant person different in pregnancy, but also that pressure that's being communicated through the placenta to the fetus also exists in pregnancy. So 160 over 110 remains the emergency threshold for treatment in pregnancy. So if that number is sustained, over, repeat check, and then you need to treat them with either IV medications, or if there's no IV available, immediate acting oral medication. And there are well-defined algorithms for how frequently to check, how often to give the medication that I still look back to this day. So you don't have to rely on our memory. You can just look at these algorithms. Now, where we've started to shift a little bit is on the other end. So we also used to relax a little bit more on treating high blood pressure that wasn't in the severe range. So typically, if you have somebody who's going through pregnancy, whether they have underlying hypertension or not, if they got to 140 over 90, which helps make the diagnosis of hypertension in pregnancy, you say, okay, we can kind of let this continue a little bit. Let's watch until it gets to maybe 150 over 100, and then we should start to treat them, especially if they're at a low enough gestational age where we want to give more time for the fetus to develop. And 150 over 100, when we look at it on the flip side, for somebody who's non-pregnant, yeah, it's not an emergency number, but it's also not a number you want someone comfortably sitting at. And so why did we let pregnant people sit at this number? Well, there's this understanding that, as we talked about, whatever's happening to mom is also, or pregnant person is also translating to the baby. So if a baby or a placenta is used to seeing some blood flow from a blood pressure of 150 over 100, and you tank that number, then all of a sudden you're concerned that you're like taking away a lot of the blood flow from a baby that needs to be perfused, that needs to get blood to its organs. And so we used to let pregnant people kind of relax and hang out until they got over 150 over 100, and they're pushing that, high numbers before we started treating them with oral medications during the pregnancy or after delivery. And what the data started to show and the evidence has started to show is, actually treating them to at least under 140 over 90, one, doesn't compromise the babies in the way we thought it did, right? We don't have higher rates that we're restricting their growth and signs that we're not getting them enough blood. And like any normal person, we're subjecting the pregnant person to less effects of high blood pressure. So I think the takeaway is that 160 over 110 remains the emergency number. Like I said, more sensitive blood vessels, higher risk of stroke, abruption of the placenta, and other fetal effects. And then now 140 over 90, if someone is consistently above that range during pregnancy, after delivery, we should be treating them and putting them on oral medications. At some point, if someone's 37 weeks, that's a whole nuanced discussion, or even 35 weeks, maybe it's not worth treating and just looking at delivery. But, by and large, especially earlier in the pregnancy, 140 over 90 becomes the threshold at which we should start giving oral medications to keep people in a more normal blood pressure range.
Fantastic. You worked your way through those nuances clearly, and I know that's helpful to our audience today. Eleni, I'm going to move over to you, risk headquarters for preeclampsia. Speak to us about who is at risk for preeclampsia. And I think we have a slide.
So I think we have a slide to help walk us through this. If we could pop that up, that would be really helpful.
There we go.
So this actually covers a couple topics, and I'm going to start with just looking at it through the lens of risk factors for preeclampsia, but it ties to one thing that we know we can and should be doing, which is prescribing aspirin for certain populations who hit some of these risk factors. And, I just want to underscore the points that have made already, which is to some extent, I think the take home message for everybody is at risk. Even if you don't check any of these boxes, it doesn't mean you will not get preeclampsia or some kind of hypertensive disorder of pregnancy. So I'm always a little bit careful in talking about risk factors, because some people will instantly, especially if you're talking to a patient population, they'll sort of mentally check off like, nope, don't have that. Nope, I'm good. Nope, 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 good. Okay, next. and the reality is that we all need to be on alert for this. There are, however, some people who come into that pregnancy with higher risk factors. So the way this chart is organized is in this high, moderate, low. And in high, we look at if you've had preeclampsia before, you are at higher risk for getting it. Like you should be on higher alert just based on that history of having had preeclampsia. If you're carrying more than one baby, if you come into that pregnancy with chronic hypertension, as we've already talked about, and then if you have some other comorbidities like diabetes, any kind of kidney disease, any kind of autoimmune disease, all of these absolutely put you at higher risk for developing preeclampsia. So those are what we would consider the highest risk factors. In the moderate risk factor category, I probably should have reordered these because there's increasing evidence that obesity, number one, it may not only be a moderate risk factor, it actually may be moving into the high risk category. But for now, the two main bodies that support this chart, the ACOG and the USPSTF, both have gotten behind this categorization. So never having given birth, I sort of jokingly say you're guilty until proven innocent when it comes to how your body is going to respond to pregnancy. And so that is considered a moderate risk factor. Obesity, as mentioned, a BMI of greater than 30, having a family history, if your mom or sister have had preeclampsia, older moms and younger moms are both ends of the maternal age spectrum have that contributes a moderate risk factor. And then if you yourself are the product of a preeclamptic birth, or you yourself came had very low birth weight yourself, those are contributing factors. And then there's this whole constellation of social drivers of health, which gets into a whole other important but somewhat complicated conversation about how you understand those and how you add those to a chart of risk factors. The simple answer is really the only people who would be considered at lower risk is if you've had a previous completely uncomplicated full-term pregnancy. And that means that almost everybody falls into at least some of these higher moderate risk categories. So how does all this relate to aspirin use? Essentially, what healthcare providers should be doing is prescribing low-dose aspirin to patients who exhibit any one of the high risk factors or two or more of the moderate risk factors. And that aspirin really needs to be started really no later than the first trimester. I know some of the language around it lets it go till later, but when you think about when the placenta is forming and some of this vasculature is forming, we really need it onboarded no later than the first trimester for it to have the effect that the studies have shown it can have. I won't go too much more into great detail about aspirin usage, but I will point you to the QR code on your screen, not only because it describes this whole process in more detail, but also because there is a really nifty little applet on the website that you can encourage your patients to use. And the reason we say that is because one of the issues that we're finding in some of the studies that have looked at aspirin is adherence to aspirin. If you have been told, yes, you should be taking aspirin, adherence is a little sketchy. And we think that one of the things that we're seeing is that the more patients can sort of have that self-agency and engagement, and, a lot of times we'll talk about shared decision-making and really being a partner with your provider in making decisions like, should I be taking aspirin or shouldn't I? If the patient walks through this little applet, they're going to self-identify some of the risk factors, and they're going to see where the evidence is pointing to, oh yeah, I should be taking aspirin. And that self-agency contributes a lot to higher adherence from what we're seeing. So I'll leave it at that for now. Happy to dive deeper into any of that. And of course, our that our two obstetricians on the call will probably have more insight to share on this too.
Thanks so much, Eleni, and I love what you've done with the applet. I think we will move to a resource that the Preeclampsia Foundation under your leadership has provided and launched. Please tell us about the cuff kit.
So this is kind of the heart of this whole conversation, right? SMBP, so self-measured blood pressure. And if we can go to the next screen, we'll see a picture of what we've included in our cuff kit. This was born out of what became almost an immediate telehealth environment during COVID. But I'll tell you, it speaks to the heart of what the Preeclampsia Foundation is all about. And that is that idea of empowering patients with information where they can come to their pregnancies and the postpartum period as empowered patients. And what do we mean by empowered? Empowered with knowledge. We're big drivers around symptom education, and you see in the chart there our symptom tear pad that is a whole other conversation, but it really speaks to the need for patients to understand what are the most prevalent symptoms that they need to be aware of and responsive to. But the other side of symptoms are signs, and the sign of high blood pressure is critical to screening and diagnosing preeclampsia. And if you're not being seen more than once a month, which is often what happens in pregnancy, if we're moving more toward a telehealth environment, which is something that we anticipate happening with a lot of prenatal care, and certainly in the environment of something like COVID, then the importance of a patient taking her own blood pressure and understanding how to do it accurately, what the numbers mean, what I should be doing as a result of the readings that I'm getting, all of that is part of our blood pressure campaign. We call it the Check, No, Share campaign. And the cuff kit, which you see a picture of it on your screen, includes not only a device that's been validated in pregnancy, but also includes educational material, and it's accompanied by a lot of video educational material. Like we know that learning has to happen in a multifactorial way. You've got to read it, you've got to see it, you've got to hear it. And so all the education around how to take your blood pressure accurately, when to take it, how to record the numbers, and offering a digital solution for people who really don't want to sit there and transcribe numbers. It's all built into a free app that goes with this program. So the Cuff Kit project, at this point, we are, I think we're approaching a distribution of 30,000 of these cuff kits. One of the keys is that they are distributed through providers. We are not sending them directly to patients. And the reason is because you need to be connected to a provider so that if you do have concerning readings, you have a linkage to somebody who can do something about this. There's nothing more frustrating as a patient to have information and not know what to do with it, where to go with it. So we really want these kits to be distributed by providers who are trying to enable some of their highest risk patients to be monitoring their blood pressure at home. And we know that that certainly is something that has been taken up a lot in a non-pregnant population. Now, with all of the focus on what's happening with maternal mortality and morbidity and the inequities that we're seeing, a tool like this, and it really is a tool, there's an opportunity for providers to really equip their patients to become those partners in their healthcare.
Thanks so much, Eleni.
Oh, let me make one quick little side note, because this won't apply to everybody, but one of the pieces of this program that has been especially interesting to some of the groups that we're working with is that we do collect data. There is a research component to this. It's optional, but there are a lot of people who have really gotten enamored with the idea of, hey, let's actually collect data about how this is working, because ultimately the goal is, does an intervention like this, does a tool like this actually impact outcomes? Does it reduce inequities? Does it improve outcomes? Does it speed up time to diagnosis? We know that some of the most horrific stories have happened because mom gets to care too late, and then we're dealing with crisis. And I know the doctors on the call do not want these 11th hour emergency C-sections to try to save lives. It's much better if we have leading indicators, and something like SMBP would give us that leading indicator. So we're collecting data along those lines and partner with a lot of groups to do that in a way that they can use the data.
Fantastic. Thank you. And again, you made the point that it's not about the cuff, or not just about the cuff. It's about the team gathered around those using that cuff. So Dr. Green, Family Christian Health Center has actually been using SMBP during and following pregnancy, or for people during and following their pregnancy. You have road rash. You have pearls to share with the group today. Can't wait to hear what you have to say.
So, first of all, I'm just honored to be on the call. And as, we were talking and listening to everything, I was like, boy, women, we have so much on our plates, right? So we have to take our blood pressure. We're trying to figure out if we go into the grocery store, Instacart, just all these things that we're asking, women to do, yet we know how dire this is. And so I think that I'm just grateful that we have now how it's getting the attention that it is, especially because it's something that we can prevent. And I will tell you, for us, as great as we knew the tool was, one of the hardest part was like, how do we implement this, right? Because our providers have to talk to the patients, right? And they're competing with so many different things. It's hypertension, somebody's got diabetes, it's cholesterol this month. It's a host of so many other things to do. And when you look at our workforce right now, people are tired. And so the limited resources, a lot of times we rely on, our medical assistants, and our medical assistants are short-staffed. And so how do you take this great idea, great program, great kit, right? But the information still has to be connected to a provider. Somebody has to watch that data. The patient has to understand and have somebody to follow up with them, that it's important for them to use this, right? And so one of the first obstacles that we had was our, medical director was like, Dr. Green, I got a list of 20. All of these are important. How do I prioritize this? And so it was really meeting with our leadership team and looking at the data, just like you were mentioning. That data was so compelling, but you have to get the buy-in of the team, because the team has to believe that they can do it and see what the impact is. It's not that they didn't think it was a great effort to do, but what's the reality? And no one wants to really start something if I'm not going to have the results that we need to get from the patients. And so once we got through that part, the next step for us was to then sit down with our medical students and our medical assistants. We had nursing students who happened to be on site with us, and we worked with our medical assistants. And the first thing we did was we sat down and did an in-service with them. I wish we had these beautiful slides at the time. We didn't have all of that, but it was really, we had patient stories. And some of them were moms. And how do you take it and make it relatable? Because the numbers are not just someone you see on a poster board, right? These are somebody's cousins, sisters, aunts. There's somebody. And if we can prevent this, then don't we owe them enough to do that, right? And make it in a way that's easy for us to do. And so once they found out that, wow, this extra 5 minutes to really sit down and get buy-in with the patient and help them explain something, it really can save somebody's life. So let me understand this first, as opposed to, just checking off the list, because it becomes a checklist. We just check it and we keep it moving, right? But that part made a big difference for us. And once the whole team was engaged, then the patients could, once they received their blood pressure kits, then you can do the education piece, then you can do the follow-up. And it became, the staff was so grateful, because then when you see changes, like currently we have, I said a small group that we have about 15 women. And of these 15 women, 6 of them, and we identified, women that were higher risk. 6 of them are using it, accurately. We call up, and it takes, so let me just not be clear. It takes time to call them back. Your number was elevated. What can we do? And then having those conversations with people. But for this month, 2 of those 6 who are identified as high, we've been able to make some changes. So that's a great thing right now, that we are being able to do that now, as opposed to the end, right? And so the staff get excited about that, the patients get excited about it, and the opportunity that you have is that blood pressure kit really allows you the ability to engage with not just the patient, but the patient's families. We saw that a lot of them involved a sister or aunt, their significant other. And then we're talking to them about food, and like, oh, Dr. Green, yes, I went to Popeyes last night, and I know I didn't eat that 6-piece with, mild sauce on it or whatever, but you know what? I see now what happened with my blood pressure, and so the family says, okay, so next time, you know what? If you go, you only getting 2 pieces. You're not getting the 6-piece. But it has become a tool to educate just not the individual, but to educate the family as well. And then the doctors now see that as a part of the army, right? We work as a team. From the midwife to the doula to the provider, the OB to the medical assistant to the clerk at the front desk. All of us, it takes a team to really able to provide community health. And I think that's one of the advantages that you do have, in a community health center, is because you already have a relationships with those patients. So that way they don't feel like they're a number and they're not overwhelmed. I could be overwhelmed when you were talking for a second and my mind was like, okay, the blood pressure is 150. No, it's 150 over 110. And I'm like, wait a minute, how many degrees do I have? And I'm still listening to the numbers to make sure what I have in my head matches up with what you were saying. And so imagine we're trying to tell the patients that, and they're just trying to figure out their grocery list or the bills that they have to do, or how they're going to get the one kid from daycare or make lunch for the other one. And so making it simple enough, making it attainable, the app that you guys have with the preeclampsia as well, it's making it simple for people to take something that's complicated and so life-threatening to something that's doable and tangible, and that I do have, and it empowers me. This education and this tool is going to empower me. There's a lot of things I may not be able to control. Right? But if this gives me some sense of control, some sense of effort that I'm doing the best that I can, to move and to make sure that I have a healthy baby and that I'm healthy myself. The other component is that it also helps women postpartum, right? Because all the deaths don't occur in that first period. So we have women continue them for a year past that. And so it gives them an opportunity to keep on their blood pressure, because we all know once a new baby comes, I remember when I had my first kid, I had all these scrapbooks, I had all these things designed that I was going to do. I didn't do any of that first time. And so you forget about yourself. And so having the ability now to let them know that this is a journey, this is a part of your, and if that number was high, it remains high, it doesn't mean you're a bad person. It doesn't mean that you failed. It doesn't mean that you can't, it means that this is something that exists in how your body responds, and that, but now we have an opportunity to monitor that, to help change that, for the outcome of not just, you while you were pregnant, but even after that, so that you can be able to live a longer, happy life as much as possible, with your baby and your family.
Well, and to your point about the family, that lifelong investment extends to the family, not only to the person who's been pregnant. So thank you, Dr. Green. I might actually start with you, and I'll warn our speakers, we have a lightning round coming up. It'll have to be a pretty brief answer, but the question I'll ask you is, what could the folks who are joining us today, who clearly care about this topic, who care about protecting women from the harms of undetected and uncontrolled hypertension, what one thing would you ask them to do, or what piece of advice would you give them that they could look to implement this next week? What's something important that you'd recommend that they do? We'll start with you, Dr. Green.
And I think for us, it was getting the buy-in of the providers and the team. Leadership stops from the top down, but you cannot leave the people out at the bottom of the scale of that, because it's a complete circle. Like you have that question, it's a complete circle. So it has to be in competing priorities, making it a priority. And I will say the other thing to that is that that's what you do externally, but what you have to do is build trust with the patients. You have to build the trust with them, because people are afraid nowadays about, well, what are you going to do with this data? Am I not going to get insurance in the future? So there's a lot of question and concern about who has my data and what that means. And so I think it's really important to build trust with the community and being able to prioritize and build that trust with the providers, that you will have a safety net for them, that they will be able to have a support and they're not alone just as one single nurse practitioner trying to do this.
Thank you so much. I'm going to go vertically on my screen. So Eleni, you're next.
I would say education, if I could point to one thing. I mean, yes, I'd love everyone to get the blood pressure cuffs, but if you did qualify it with this week. So I would say the education piece, and it actually goes hand in hand with the trust, because what you're basically saying is, I trust you to bring, your body. I'm giving you the tools and the language to understand your body and what it's experiencing. And I'm trusting you to bring that to this partnership.
Beautiful, beautiful. Thank you, Dr. Imiriwa.
Yeah, it's so hard to pick one. So I'm going to cheat by quickly packaging two into one. And I think for all of us clinicians, patients alike, it's a mindset change. As I'm sure we'll dive into this more in the Q&A. But one is, thinking to yourself, instead of asking who is possibly at risk that I need to worry about, take a look at your patient, or if you're a patient yourself, and say, is there any reason I can reasonably believe I'm not at risk for preeclampsia? There are very few people, if anyone, who really fits in that category. And that mindset change helps us remain diligent, right? The same way you give everyone prenatal vitamins, you should be looking at everyone like, you probably should get aspirin unless, and then see if there's any they don't fit in those risk factors. And the second thing that I think is part of that mindset change is extending what we think of as the pregnant time frame. And I say this because postpartum hypertension is one of my huge areas of research as well. And so the same way anybody who has delivered a baby or who has given birth knows that you don't give birth to your baby and immediately the next day feel back to normal. And so we have to really extend what we recognize mentally, emotionally, and physically, biologically. What time it takes for your body to go back to a non-pregnant state is not the day you give birth or the day after you give birth. Like, there's weeks at least, if not months, before someone is not at risk for these pregnancy complications. And that can shift how we monitor and continue to watch people.
Fantastic. Pearls from each of you. Thank you so much. I will also ask our experts today, if you have a chance, to take a look at the questions in the Q&A block and maybe address those while we go over a few of the resources and next steps after today's session. So I think I'll just take that first slide that's going to come up after our question session. There you go. I want to let everyone on the line know that soon we'll be releasing a new change package. It's a new member of the family of change packages that the Million Hearts team has produced. This one is in the production now with the insights from our sister division, the Division of Reproductive Health, as well as I think 7 or more clinical organizations who will be co-branding this with us. It's focused on tools and resources gathered from around the country to help clinicians who are caring for individuals who have been pregnant. And it is focused on that detection and management of hypertension during and following pregnancy. We are looking for a May release and look forward to working with many of you to get that thing implemented widely. Next slide. Oh. I think we skipped one, maybe. Yep. And I think I might be the one reviewing this, but I'll say there's a wealth of resources here, many of these done in collaboration between NAC and Million Hearts. I won't go all through all of them, but you do see the cuff kit mentioned. And I also want to call your attention to CDC's Hear Her campaign with materials on how to help clinicians in particular better pick up on the clues that women are saying in their interactions and visits. So next slide, and I think I'm turning it back over to Leanne at this point.
Thank you, Jana, and thank you to all our panelists for such a lively discussion. So glad that you could all join us. So I'll be really quick here. We welcome everyone to join us for our upcoming learning labs. We also extend the invitation to your colleagues, peers, and connections. You can just register by scanning the QR code on the slide that you see here. So we look forward to seeing you all there. And then the next slide, please. I will just take a moment to talk about the CE, or continuing education unit. So to receive CEs for the Million Hearts Learning Lab course, we ask that you first register and complete the course on CDC Train, which is linked here, pass the post-assessment at 75%, complete the evaluation, and then visit Your Learning to access your certificates and transcripts. So you can see that we offer 0.75 CE hours for CME, CNE, and CPE, and 1 hour is offered as a CEU, and 1 hours are available for CH credit. This does need to be completed by February 12th, 2024. And then next slide, please. All right, we thank you all for joining us today. Again, we look forward to seeing you in future learning labs. Please stay safe, healthy, and have a wonderful rest of your afternoon. Thank you all for joining us.